in June.
Sorry.
In June, and at that time, one of my, I think I did not make clear things to one of my colleagues, and he understood the whole thing a little bit differently. So the case was actually a 59-year-old gentleman who actually had 2 years ago, he presented with proteinuria and had biopsy done, which showed membranous segmental sclerosis. His workup for, and I should tell you, no NEL antigen was done because it was not available at that time. And malignancy workup was negative in that guy. 2 years later, he presented with pulmonary hemorrhage and picture of RPGN with creatinine of 700 micromillimole. I'm sorry, I'm using Canadian units here. He ended up being on dialysis, and his anti-GBM ANCA all were negative, but his biopsy was very consistent with the anti-GBM disease, except his anti-GBM antibody by ELISA was negative. He was, we don't have plasmapheresis at our center. He was appropriately sent for pulmonary hemorrhage to one of our tertiary hospital, and he recovered from that. He was treated with cyclophosphamide and prednisone, and then he returned back home. He's on dialysis at that time. We did the subclassification of his immunoglobulin, and it was IG4. And I was trying to convince my colleagues that IG4 antibody against alpha-3 gene actually may not pick up anti-GBM antibody by ELISA. You might have to do Western blot, because that may have chains of 1, 2, and 4, and 5, so they can pick it up, hopefully, but that's not available to us. And that was the message. When you have a patient with rapidly progressive glomerulonephritis with pulmonary hemorrhage, and anti-GBM is negative, make sure to do subclassification of your IgGs, and you will be very surprised it will be IG4-related disease. And for some reason, these patients have more pulmonary hemorrhage than anybody else. Dr. Glasser can comment on that a little bit later, because he wrote a editorial on a couple of very interesting patients in 2016, indicating lesson learned from those 2 cases, and this may also be part of that discussion. Now we like to go to, and that's the article I was quoting. It's a very interesting, if you people have not read it, it would be worth reading it. It's a very informative article. Not that Dr. Classic is here. I have read about 5 times this article. I always learn something new. Now, going back to our present case, I have my physician assistant who has diligently worked hard. She's not only my presenter, but she is also my Praveer Bakshi of our group. She handles all our technical aspects. So if there are any mistakes, she's at fault. Deepika, go ahead.
Thank you, Dr. Reen. Just before we get started with the case today, I just want to say welcome to everybody, Dr. Rodby, Dr. Whittier, Dr. Classic. Big fans here. We call it Rush Thursdays, and we're always tuning in and waiting for your biopsy rounds. And like Dr. Reen said, we've been inspired to sort of take this on because of what you guys do. So thank you once again for being here. So we'll get started. So we have a 60-year-old female that was referred after having an episode of frank hematuria, mild bilateral edema, and facial swelling 2 months ago. She also had noted dark tea-colored urine 4 months prior to this presentation and was treated as a UTI. And further questioning, she states that she's noted dark urine intermittently for the past 2 years, and on one occasion was admitted due to high blood pressure and dark tea-colored urine. Her past medical history is only significant for hypertension. On review of systems, she was otherwise well, no chest pain, no shortness of breath, no cough, no sore throat, no history of any blood in the sputum, no sort of abdominal pain or abdominal bowel disorders, no nausea, no vomiting. She did not have any complaints of joint swelling, epistaxis, no nasal crusting, no history of any oral ulcers. And on further questioning, there was no history of any TIA, no CVA, no cardiac history, no history of any respiratory disease, no history of DVTP, and no history of any malignancy. When she presented to us, her medications she was taking was Viacor, 7 milligrams, 5 milligrams, which is a combination of parenteral and amlodipine. Her family history is otherwise unremarkable. In terms of social history, she's a non-smoker, does not use any alcohol, no use of recreational drugs, no use of herbal medications, and she's actually visiting Canada. She's visiting her family. On physical exam, her blood pressure was 133/82 with a heart rate of 67. Her cardiorespiratory exam was normal. There was no edema on exam, normal abdominal exam. There were no rashes on her body, and her BMI is around 21. Okay, thank you. So with the lab work, when she was initially referred to us, her creatinine was 152. And by the time we had seen her, it was 185 with a GFR of 25. Her UACR was 27. Hemoglobin 89, platelets 328, potassium was 4.2, sodium 145, bicarb 25, calcium was 2.41, and phosphate 1.39. Her albumin was 47. And on urine test, her 24-hour urine protein collection showed 0.69 grams per day. Urinalysis showed 0.3 grams per liter of protein, and blood was 200 RBCs per slide. She did have a kidney ultrasound. The right kidney measured 10 centimeters, left kidney measured 11 centimeters, and there was the renal cortex echogenicity was normal. On some further tests, her rheumatoid factor was normal. ANA was positive with a titer of 1 to 320. Her dsDNA was negative. C-ANCA, P-ANCA were both negative. C3 and C4 were both normal. So C3 was 1.24, C4 is 0.32. Her IgA levels were 2.94, IgG 17.48, and IgM 0.46. We did do an anti-GBM with an ELISA, and that test was negative. Her serum free light chains, her free kappa chains are elevated at 74.8, and free lambda chains 34.9. And the kappa lambda ratio was 2.14. SPEP was normal, and urine fixation was also did not show any monoclonal band. So once we had sort of her history and her results, we did perform a kidney biopsy. And once again, in terms of her creatinine, 152 was the most recent number we had because she was visiting, but we weren't sure what her prior baseline was. So I'll pass it on to Dr. Buller to walk us through the biopsy.
Any question about protocol?
What race was she?
She's South Asian from India, actually. I should add that hepatitis B and C were negative. Her LDH and fragmentation schizocytes were negative in the blood, if anybody is interested in that.
I may have missed it, but what was her protein excretion rate?
It was, I think, 0.69 gram per 24 hours.
6.9 grams?
0.69.
0.69. Okay.
Can you show up at Dr. Glasek that if you go back a little bit?
700 milligrams.
Yeah.
Got it.
700 milligram per day. Okay.
Okay.
Any other questions? Okay, so we are going to show. Sorry?
Should I take over now from now? Or?
We are going to show the biopsy and then we will have a poll.
Sure.
Okay, so Dr. Buller, just click on your screen and you'll have access to the slides. There you go.
Yeah. So what I received were 3 to 4 cores of renal parenchyma, and this is a low power view on H&E stained sections. In this magnification, you can see that it looks busy. The glomeruli look busy, as well as the tubular interstitium looks a little bit busy there. And most of the glomeruli look like this. There was no real open capillary loops that was visible easily, and definitely there was evidence of glomerular hematuria with tubules with RBC cast, and there were some tubules with granular brown colored cast, what looked like hemoglobin cast to me, and I'll come to that a little later. Going to the next slide. This is a high magnification, that's a PA stain section. As you can see that definitely there were capillaries with very prominent endothelial cells, and some loops showed this neutrophil polymorphs, and that's a monocyte there. So definitely there was focal and segmental endocapillary hypercellularity. And the background tubular interstitium, you can see that it looks busy again. It looked inflamed. There was a single glomerulus which showed this fibrin exudation, that eosinophilic material. What you see is pale PS positive as well. That's fibrin, and with what looks like an early cellular crescent. That was just a single glomerulus. And this is a Jones stain section, again, trying to show the focal endocapillary hypercellularity. Those are intracapillary monocytes there. And these are prominent endothelial, plump endothelial cells. And the tubular interstitium looked very busy. There's definitely tubular interstitial inflammation. And this particular tubule, if you note, there are definitely, believe me, there were lymphocytes between the basement membrane and the tubular epithelial cells, amounting to tubulitis, and there was patchy medullary tubulitis as well. Can I go back to the previous one? Okay, this again, glomerular hematuria is tubular CAS, RBC CAS, and this is what I was alluding to earlier, these granular to globular pale brown CAS, and these stain positive with hemoglobin immunohistochemistry. And that's a Pearl's Prussian stain, which shows this blue blush within the tubular epithelial cells, a telltale evidence of hematuria. And this patient, I think, had 4-month history of cola-colored urine, so probably she's been bleeding for a while. So that's the immunofluorescence. I forgot to label these. I'm sorry about that. This is the albumin, and that is the IgG stain. Compared to the albumin, you can see that there's definitely linear staining with IgG, linear glomerular basement membrane staining with IgG, and IgM, IgA was totally negative, C3 negative. That's the kappa stain to the left, and that's the lambda, and there was definitely lambda dominant linear staining there, what we noted. That's the electron microscopy. It basically showed ischemic wrinkling of glomerular basement membrane, a mildly thickened basement membrane, and there was evidence of endothelial cell injury with loss of tight junctions. Some focally, there was loss of podocyte foot processes, but mostly they were preserved. And that is a loop with a very prominent endothelial cell, and that's the mesangial cell interpositioning. So there were telltale evidence of microangiopathic injury, something which has been going on in this lady for a while. And there were no immune type or any other electron dense deposits. We scoped about 4 glomeruli, and there was nothing visible at all. So I'll pass it on to Dr. Reen again now.
So Shubha, basically, what you are saying is that this patient had some quite inflammatory disease in the tubules and interstitium, plus TMA and Ig lambda linear deposition. That's basically it.
Yeah, basically, I was the differentials that I entertained at that point in time was: are we looking at some MGRS spectrum of disease?
Okay.
Could this be like a proliferative glomerulonephritis with monoclonal immunoglobulin deposits? But it did not fit very well, because in proliferative glomerulonephritis with monoclonal immunoglobulin deposits, as you know, the immunofluorescence would be a granular clonal
Yeah, we're going to
deprivation.
discuss, we're going to discuss that a little bit further.
Okay, sure.
That is my poll, actually. What I was going to ask you is the basement membrane was okay, or it was a little bit thickened or something like that?
Yeah, it was more a ischemic wrinkling with pseudo thickening. That apart, nothing much. And as I said, there was definitely some evidence of chronic microangiopathic injury as well. So the differentials that I entertained at that point was, could this be an MGR spectrum of disease? And also, of course, with focal endocapillary hypercellularity and linear staining with IgG lambda, another thought that came to my mind was, could this be atypical anti-GBM antibody disease? So
Okay, we were
these
going
are
to
the things that I was thinking.
Yeah, we were going to do poll on that. No, that poll is, forget about that poll. Okay. Let's
Dr.
go
Rain?
to the next slide.
Yeah.
So our, yeah, Dr.
Dr. Rain, let me just comment here because I think it's going to turn out that the electron microscopy was very, very informative. This can't be proliferative glomerulonephritis with monoclonal IgG deposits because there are no deposits.
That's right.
Sure.
So the electron microscopy excludes that condition and certainly would lead to favoring an atypical anti-GBM disease, particularly with linear immunofluorescence and lambda light chains. I mean, I guess proliferative GN with monoclonal immunoglobulin deposits would be in the differential diagnosis until you looked at the EM.
Yeah, when we were looking at that, I think when I saw the biopsy, I actually was aware what it will be. But for our teaching purposes, you are absolutely right, Dr. Kulasik, what you said. It couldn't be proliferative GN because there are no dense deposits. And if there are dense deposits, they look very granular. Light chain and heavy chain disease, one should think into that also. And but again, the deposits are not there. And if deposits are there, they look quite powdery. It's an interesting paper. When I was preparing for this talk, was a parvovirus B19 monoclonal deposits. And I do know that Dr. Kulasik has commented on one of the ASN chats. And lo and behold, it generally shows some endothelial deposits, so it doesn't show in this case. And that is one thing. So we are.
Can I ask? Steve Corbett from Chicago. I was just curious. I didn't see it, and I don't remember it being commented on. Did the tubular basement membranes light up at all?
No, nothing very impressive at all. No.
And so we were left with this gamut of disease called atypical anti-GBM disease. And that is what I thought it was, but I'm starting to change my nomenclature on this disease. I was hoping Dr. Javeri will be there because he has proposed that should these patients be called as monoclonal gammopathy of renal significance in that group, rather atypical form. I don't know, we can discuss that and have our own opinion, but at this time, we actually thought it was atypical anti-GBM disease. Anybody has any question about that it should be something else?
One more short comment is not uncommonly in patients like this, we don't have electron microscopy. Either there isn't an EM lab convenient or the specimen is inadequate for electron microscopy. So we have to do a differential based on light and immunofluorescence. And in a patient like this who has a linear deposit and shows proliferative GN, you have to include a fibrillary GN in the differential diagnosis because fibrillary GN at the level of the immunofluorescence microscope can look linear. It's kind of a smudgy linear. It's not a classical crisp linear, but it's in the differential diagnosis. If you don't have EM and if you don't stain for DNA JB9. I just want to raise that because we've had a number of cases that turned out to be fibrillary when later examination by EM is done.
But Dick, in those cases, most of the, the mesangium should be lighting up too.
Lighting up too, yeah.
Yes.
You know,
Yes,
I'm-
that's true. And that's a good point, Steve. It's not just peripheral linear. It's a combination of a smudgy mesangial deposition and linear deposits in the basal membrane. You're quite correct. You should be able to suspect fibrillary GN based on the IF appearance. And this case does not have any semblance of fibrillary GN.
Unfortunately, yeah, go ahead.
This is Kenar. I completely agree with Dr. Glassock. I put in the chat. I think fibrillary came to mind right away in the differential till the EM findings, especially when you have linear staining, diabetes, fibrillary, and anti-GBM are usually in the differential. But with the TMA findings as well, I mean the endothelial damage and a monoclonality, there has to be the monoclonal protein has to be looked at versus a drug induced. When I see endothelial damage and all these atypical findings, I think of some drug. It could be, I'm just throwing out names, but something herbal, hydralazine, who knows? But that's why
We did take a very detailed drug history. Although she is from India, I made sure that she was not taking a herbal medication or anything like that. None I could get. Her family is pretty well medically tuned. They are in the medical field, and they are very confident she wasn't taking any herbal medication. As you are right, there are a lot of herbal medication floating in India, which has all sorts of things in there. Dr. Johari, I should welcome you. Dr. Johari is a professor of medicine at Northwell, and he actually was the reason I got interested in onconephrology. I attended his course in ASN, and since then I've been following him. I have another passion common to him, which is Bollywood movies, and we love one movie, both of us. Whenever there is a comment on Twitter, we both rush and name that movie. So we have few things common other than nephrology with Dr. Johari also. Welcome, Dr. Johari. I'm very appreciative that you are here. Dr. Glassock, would you suggest us to send this specimen for DNA JB9 or no?
No, not after seeing the IM. I don't think it would be. I don't think it would be terribly revealing. Now, if you saw fibrils, yes, so then I would definitely do a DNA JB9. Some people might say before you diagnose monoclonal disease, you need to do a paraffin IF and be sure that this is not a pseudo monotypism, because occasionally you do see lambda predominance and you do a paraffin IF and all of the monoclonality disappears. I think that's commonly performed as a routine in a patient like this. But I tell you, I'm not too surprised with linear IF proliferative GN that this patient has a lambda light chain in the kidney, because that's typical for atypical anti-GBM disease. 50% of the patients with atypical anti-GBM have a monoclonal, so there's nothing strange here.
Kishan, you have some question?
Yeah, I just had a quick question, Dr. Glassock and the other experts in the room, is that, you see these typical monoclonalities associated with certain diseases. With going back to the fibrillary GN, if you don't have the EM, is it true that they're more associated with kappa light chains in those diseases? And would you use that as a differentiating factor for the fibrillary if you didn't have the EM?
No.
Well, I have seen fibrillary GN with lambda, so it's, yes, you're right. The percentage is not right, but in an individual case, I'm not sure that whether it's a kappa or lambda really is sufficiently decisive that you would make a diagnosis.
Okay.
That's just
Dr.
opinion.
Jeanette Lejoie, she was she worked with us for many years before she moved to her hometown of Ottawa. She suggested that fibrillary are generally polytypic diseases. And unfortunately, we could not do the subclassification because
there were no glomeruli.
cortex was exhausted. So Dr. Glasek or anybody else, is a light chain, heavy chain antibody will help us in this defining what type of, is it monotypic or polytypic disease or no?
Well, there have been reports, very rarely, of a monoclonal immunoglobulin having reactivity with alpha-1 and alpha-2 chains.
Mm-hmm.
Typically that's kappa, but there's only 2 or 3 cases in the world's literature
Mm-hmm.
of a monoclonal with reactivity to call for A1 and A2, which would not be detected in the ELISA assay. Those are extremely rare. You would have to prove that this patient's lambda reacts with alpha-1 and alpha-2, which means you have to do another assay.
Yeah.
Now, the Mayo Clinic has reported 2 cases.
Mm-hmm.
I think that's probably the whole world's literature. It's very rare.
I read that paper, yeah. Any other questions from the panel or any people who are on the call? Okay.
Yeah, good evening. Yeah, it's Rick Dillon here. First off, Dr. Reen, really, appreciative for organizing this. Just at the hospital, so you can't see my, face right now, just on the phone. A lot of, great personalities, on today's call. I missed the first bit. There was TMA there, and was there crescents in the biopsy as well? Was there any crescent?
There's a single glomerulus with early cellular crescent.
And
I'm not sure I understand why the concern about TMA. The patient has evidence of TMA, but 8 out of the 20 cases originally described by the Mayo Clinic who had atypical NAGM had TMA. There's nothing very surprising about the presence of endothelial injury and a little bit of mesangiolisis, and maybe even enough TMA to be overt. That's
I think
part of the syndrome.
Yeah, no, I think the reason, I brought it up was just, a lot of anti-GBM, a lot of crescentic inflammation, a lot of the classic cases there. And sometimes when you do have TMA, you can get the thrombotic process and the vascular lumina that kind of blunts that, anti-GBM crescentic response. So I was just just asking from that perspective. But yeah, I totally appreciate what you mentioned, Dr. Glasek.
Okay, then go ahead.
I've got a question. We're talking about the glomeruli, but my recollection was when we saw there was a lot going on in the interstitium as well, right?
That's right. Yeah.
And I'm trying to figure out how to tie all that together with what was going on in the glomerulus. There's no question in patients that have necrotizing GN or crescentic GN that when Bowman's capsule, I guess, breaks, there are going to be a lot of inflammation around the glomerulus. But man, it seemed like you were talking about tubulitis and a lot of other things, and I'm still trying to figure out how to tie all that together.
It's a good point.
I mean, I have to admit, maybe some viral type process, I guess you could tie into this, but it doesn't explain these monoclonal deposits. And parvovirus B19, I guess, whenever I think of that, that could definitely cause, I guess, tubular interstitial inflammation, but the glomerular lesions, and there may be immune complex associated parvo B19, but, Cynthia Nast and others, and a lot of people talked about the, collapsing FSGS, and I don't think I saw anything that looked like there was a lot of epithelial cell hyperreactivity.
Yeah.
So it's still an enigma to me as to how to put everything together.
There wasn't a complement cascade analysis done, was there? Obviously the C3 was negative. I'm not saying this is something like C3GN, but was that sent off or thought of? Sometimes
We
the
have-
monoclonal immunoglobulin can impair the pathway and then lead to complement activation over time, leading to sort of a TMA type process.
Actually, you are right. Immunoglobulins do affect complement and either directly or indirectly. We have sent her complement genetic studies, and it will be interesting to see it. We are restricted by many things financially because she is a visitor and she has a very limited medical coverage. I think my staff has done a wonderful job of getting investigations which are quite expensive. Even to get a kidney biopsy was a big deal. But we are trying our best to get as much as we can. But we were lucky to get some help from the people who do the genetic studies free of charge. So hoping to get those results.
Yeah. I'm sorry. The other interesting thing is, from my recollection of the history, this isn't something that just happened. She's been having this for some time, right?
Exactly. Yeah.
I mean,
For 2 years she's having it.
I thought for sure we were going to see IgA nephropathy.
Well, actually, that's why I wrote in the Twitter, it is everything but IgA nephritis, because most of the people don't waste their time.
I mean, the other thing I thought you were getting at when you were showing the iron, like was some sort of a, PNH, paroxysmal nocturnal hemoglobinuria, where these people can definitely over time develop a lot of iron deposition into the interstitium and chronic disease. But that didn't seem to pan out either.
No, nothing.
I defer to Dr. Glassick and everyone else. I have no idea how to tie this all together.
Yeah.
Actually, I'm glad you asked that question, Dr. Corbett, because that was my question, which I have not been able to explain either. Okay, next slide. Just for Dr. Dillon's sake, I can assure him that in the atypical disease, there are definitely found some TMAs. As a matter of fact, 40% of the patients, more so in polytypic than monotypic. And there are also some focal crescent, as evidenced by Nasser's patient paper in 2016. So I wasn't surprised to see TMA, as Dr. Glassick already mentioned it. Next slide. So our diagnosis was that because of these findings. Next. This I stole from Dr. Javeri's paper. So there are actually all these patients with monotypic disease are here. The first one was described by Houghton. That was an IG3 lambda monotypic. Nasser had about 8 of them. And then there are Dr. Bunella paper, which Dr. Javeri is a co-author. And in that paper, actually, they mentioned they should be called as a monoclonal gammopathy. I will be interested in Dr. Javeri's comment. Why does he propose that name? If there is any reason which we can have a discussion about that. And more important thing is that there is another, which we didn't put in our, she did put. There is another case which is not in that. There's Dr. Behranawala. So there are about 15 cases with the monotypic disease, and they are half and half lambda and half kappa. So there are not many patients. So if our patient is monotypic, I don't know, because we don't have the subclassification. That may constitute the 16th patient. So they are rare, but I think anybody who has a hematuria, rising creatinine, and or other one should consider biopsying these patients and not waiting for them that it's an IgA nephritis from that point of view. Next slide, please.
Dr. Reen, can I just, Hitesh, if you had the subtype and it was not, say it was an IgG4, most commonly we'd expect a 1 or a 3. Would that make you think less likely it's an atypical anti-GM?
Yeah, that's true. because as Dr. Classic will agree, there are, I would have thought there's those, I didn't think it would be IG4, a reason being, although she had indolent colds or a little bit subacute colds, but she didn't have pulmonary hemorrhage. Generally, patients with IG4 for some reason have pulmonary hemorrhage, as I mentioned in the very beginning of when we started the talk. Is it possible? Of course it's possible. Medicine not 100%, but I would have thought there will be a little bit more pulmonary hemorrhage type of picture. Dr. Galasik, do you have any comment on that, sir?
No, I think, you know, we brought up all the key points here. The paper and the title have been criticized because, of course, no one has ever demonstrated anti-GBM activity in any of these patients. The diagnosis is based on the linear appearance of the deposits, which suggests that it is an antibody reaction with an intrinsic basal membrane antigen, but no one has ever eluted antibody off these specimens and shown that it will react with normal basal membrane. Nobody knows what the epitope is that the supposed antibody is reacting with. And although after they reported this paper, they did go back and do Western blots, and they were negative as well. So it's unlikely that this anti-GBM is directed to a non-classical epitope like alpha-3, which is the epitope that is measured when you do an ELISA assay. If you would do an ELISA assay with an anti-3 substrate for looking for an antibody to alpha-3, and the patient's antibody is 100% alpha-4, it'll be negative. Yeah. But it's still anti-GBM antibody, but we don't know what the epitope is to which these patients are developing antibody that is deposited in the kidney in a linear fashion.
So just to summarize these cases, there are 15 cases of clonal linear GBM cases described in the literature. Generally, they are middle-aged, slightly male predominance. Average creatinine is 165 micromillimole, and there is an equal distribution of lambda and kappa. Dr. Classic, if I propose that these should be grouped under monoclonal gammopathy of renal significance, and you will come back at me that there are no monoclone in the blood, is it possible that it's a sink phenomenon type of thing, that everything absorbed by these things are physiochemical affinity, these monoclonal go into the basement membrane? Is it possible, or I'm just imagining things?
Well, the sink phenomenon certainly works for anti-PLA2R antibody. Whether it works with anti-GBM is not known. Now, 50 years ago, I did a study where we measured antibody before and after bilateral nephrectomy in a group of patients with anti-GBM disease. We published it in the Journal of Experimental Medicine. And all patients had an increase in the circulating antibody after nephrectomy, which would indicate that if you're synthesizing anti-GBM antibody and you take away the antigen, the serum level will go up. Well, of course, none of the patients with atypical anti-GBM disease have ever undergone bilateral nephrectomy. They never will, because they have relatively normal renal function, and it's not a rapidly progressive disease. And bilateral nephrectomy has now been abandoned as a treatment for anti-GBM disease. It was thought that it might help slow accelerate the rate of disappearance of the antibody, but it does just the opposite. It increases the antibody level. So I don't know how we can resolve the issue of a sink, an immunological sink, in a patient with atypical anti-GBM. I don't think there's an experimental way in humans to get at it.
Yeah, but if I could add something, you know, not all monoclonal gammopathy of renal significance is you find anything in the serum or the urine. I mean, it's defined by the light chain restriction. So
That's right.
even if there's not a sink, I mean, I don't know how you, unless, you know, you did the pronase and turned out it wasn't monoclonal. I don't know how you can't somehow put it into the monoclonal gammopathy of renal significance category in my mind.
I agree.
Okay, next slide.
You know, just like monoclonal proteins or light chains or heavy chains can directly affect the endothelium and cause thrombotic microangiopathy, is it possible that the heavy chain or light chain in these diseases is directly affecting the GBM and causing like a linear type of pattern, but it's not really the true anti-GBM?
Yeah,
and it's we're learning more about these diseases because the names were different back 10 years ago, 20 years ago. And a lot of these tests were not done, and hence they were classified differently. We learned that the hard way for post-infectious GN and C3 GN. So I just feel like we have to keep an open mind in some of these diseases and at least look for a secondary cause. I feel in this patient it's still a drug, given the interstitial nephritis, endothelial damage, and all this anti-atypical finding. I feel like there's something triggering all three things.
Good.
I saw, Dr. Reen, I saw a post on IgG4, anti-GBM disease. I want to point out that nearly all of those patients had pulmonary hemorrhage.
Yeah.
Pulmonary hemorrhage is the signpost of an IgG4 mediated. Now, you could have done subtype staining on this biopsy, and I would predict that it would be subtype 1 or 3.
Yeah.
The question is, and I think it's a very good one, what if the heavy chain is polytypic and the light chain is monotypic? That's not a monoclonal gammopathy.
Yeah.
And they did not do stains in the original study. There are no stains for the subclass, and there's no use of the hybrid heavy light chain antibodies that are now used for defining an MGRS. So we need to be a little bit careful about calling this an MGRS until we know that both the heavy and the light chain are monoclonal. Do you know that whether the heavy chain is monoclonal in this patient?
No, we don't.
No, we didn't have enough tissue left in the fresh tissue,
Okay.
and glomeruli left, so we couldn't do the test.
Dr. Javeri, what do you think about that?
No, it's a good point. I mean, I think going forward, I think a lot of these cases we really need to be more careful and classifying it. Otherwise, these patients might get drugs that shouldn't be getting.
Yeah. All right.
Dr. Javeri, I'm going to relook at her drug history, but I'm pretty confident that she wasn't taking any drugs, counter or off the counter or anything else. But we relook into your point is well taken. Could COVID vaccine have anything to do with it, Dr. Javeri?
I mean, I've seen everything with the COVID vaccine, but doesn't mean it has an association. I mean, it's just true and unrelated. But, there have been reports of, I think, anti-GBM with COVID and with the vaccine. Interstitial nephritis, it's possible. I've seen a checkpoint inhibitor induced along with the COVID vaccine. Both activate the immune system. But, I think those are just, we have to be careful causing that association.
The reason I brought it up, this was a paper written recently where with immune checkpoint inhibitor, there was an anti-GBM plus interstitial nephritis. That's why I asked that.
Did the patient ever have a bone marrow biopsy?
Yes, I'm glad you asked. And I was
To see if there's any kind of light chain restriction or
nothing normal. Can you show the biopsy bone marrows? Do our hematologists around there? Hematologist oncologist? Dr. Covella, you are on the call?
I'm on.
Okay, this is our oncologist, and I had referred this lady to him, and he did a diligent workup, and he did a bone marrow, and if I remember, it was no restrictions were noted. Am I right, Dr. Covella?
I believe so.
Okay. And flow cytometry was also not suggestive of any clonal disease either.
Correct.
Okay, now what did we do? Can we go to that, Deepika? So what I did when she came in, so I put her on steroids, a small dose, 30 milligram, and I put her on cyclophosphamide also, because I was looking at the literature and everything has been used in these patients. So, her frank hematuria disappeared, but she still has dipstick hematuria. Her creatinine improved, which was not surprising, as there was a lot of interstitial disease also. And but unfortunately, with cyclophosphamide, she developed what appears to be a hemorrhagic cystitis, but at the same time, she also developed COVID. So we had to stop cyclophosphamide and continue to prednisone. Now the next step is because I don't know what to do, so I gave her some Celsat and prednisone so I can cut down the prednisone. And my next step will be rituximab if she continues to have hematuria. And I'll welcome comments what other people do, especially the experts.
How much oral cyclophosphamide was she taking?
It was adjusted to her dose. It was 50 milligram twice a day. It was adjusted to her EGFR and everything. So it was 50 milligram twice a day.
So you're giving it twice, because I have to admit, I've rarely seen gross hematuria. And in the lupus trial, when they did this years ago, they only gave it once a day, and they made a point to give it in the morning and make sure that the patients were well hydrated, so that acrylin, which is thought to be, I guess, the byproduct that can cause a hemorrhagic cystitis, didn't accumulate in the bladder overnight and cause irritation. So I wonder if twice a day, especially if she took it closer to the evening, that might have had something to do with it. But that's interesting.
I didn't think of that, but I'll keep next time if I use cyclophosphamide. I generally have used once a day in different patients, but I don't know why we use twice a day. Am I sure hematuria is different cause? It's possible. This time, when she had, when we gave her cyclophosphamide, it's possible that she also had a concurrent COVID. When she was talking to me on the telephone, she was having cough and sore throat. I said, do the COVID test. So it is possible COVID might have precipitated her hematuria also. It's possible. But I just, because at that time I was seeing her by a telephone that day. So I can't really be sure it was cyclophosphamide induced.
Vijender, can I ask you, say theoretically, if your bone marrow flow was suggested a clone, would that change your treatment? Would you use, and now you're thinking maybe it is an MGRS, would you use bortezomib instead of Ritux?
Well, I'll refer to hematologists. Absolutely. If you find a clone, you do a clone-directed therapy, of course.
Yeah, I would agree with that. You would treat the clone accordingly, right? If it's a myeloma type or plasma cell type clone, you would use a bortezomib combination. On the other hand, if you see a lymphoma CLL type clone, then rituximab would be a preferred option, not bortezomib.
I must tell you that there are occasions where you're not going to find anything in the bone marrow either. And if you truly have a monoclonal protein in the kidney, I mean, I have a patient that we had biopsied twice down here, and then went to the Mayo Clinic, and as usual, when they did pronase digestion, they found that the patient had an MPGN with a monoclonal protein, and serum and urine had never been positive for a paraprotein, and the biopsy of the bone marrow wasn't. But for sure in the kidney, they were able to isolate this monoclonal protein and treat it with Cyborg D. And I had given him rituximab, MMF, and his proteinuria continued to be 4 and 5 grams. They put him on Cyborg D, and the next thing you know, the guy's in remission. So yeah. I don't know that you have to, I think there are cases like this where if you're convinced that the protein in the kidney is a monoclonal protein, for whatever reason, they're not able to find a monoclonal chain or at least a restriction in the bone marrow. Maybe it's just too few plasma cells making it, but they still have evidence of injury to the kidney with a paraprotein. I don't know that you always have to have, and the hematologist can speak to this much better than I can, that you always have to isolate it in the bone marrow if you can isolate it in an organ.
If I can add to that,
you find a clone. So most of the time, 90% of the time, you'll never find a clone. And you'd have to empirically treat either with a B cell therapy or anti-plasma cell therapy. I mean, given the interstitial infiltrate, was that checked? What type of cells were those? I'm just wondering now if there's a B cell disease here that's CLL-like.
Yeah, were the cells in the interstitium phenotyped at all?
Dr. Wheeler?
Yeah, I mean, were they tested for surface antigens, differentiation antigens? Infiltrate.
I don't think so, but I'll ask Dr. Bueller. Is she got?
I mean, they didn't look like plasma cells. They looked like lymphocytes.
Yeah.
At the magnification I saw, it wasn't a plasma cell or eosinophil rich. It was more or less the typical chronic lymphocytic infiltrate. But the question is, are those neoplastic lymphocytes?
Correct. Like, could they be?
And I think that's a very legitimate question. Because of the disparity between the glomerular findings and the interstitial finding, as Steve has pointed out. A lot more going on in the interstitium than you might have predicted when you see crescentic disease and intact Bowman's capsule, you don't expect to see a lot of interstitial inflammation. And there were no tubular basement membrane deposits. So we don't have any other source of immune complex mediated. So yet we have monoclonality. I think doing phenotyping of the interstitial lymphocytes is a good idea.
I will propose to my pathologist. Yeah.
I can tell you, I mean, I've seen a lot of these cases, mostly on referral, and I've been very reluctant to treat them with heavy immunosuppression because they tend to have a very indolent disease, and there's no evidence of efficacy for any treatment. And I tended to be more conservative. Maybe I should change my attitude here and use Cyborg D in these in more patients.
I don't know.
If I can make a comment.
Clone that. Oh, sorry. Go ahead.
If I can make a comment I'm certainly not expert in these conditions, but at the recent myeloma meeting in LA, there was a lot of concern by the experts about the use of cyclophosphamide in developing secondary MDS and AML. And the thinking was we should really try and minimize the use of alkylating agents in these patients, maybe even omit it and focus more on bortezomib than using cyclophosphamide. And the comment was made, and I'll defer to nephrologists here, it might be better to wind up on dialysis than to end up dying of MDS in 10 to 15 years.
That may be true. If I want to expand on something Kanar said, that 90% of the time you don't find anything in the bone marrow. You correct me if I'm wrong, but when they do find something in the bone marrow with these, I think it's about 50% plasma cell and 50% lymphocyte, something like that. So it's kind of a toss-up if you're going to treat them empirically. I think it's kind of a toss-up. And at least what I know, that when I asked Nelson Lung about this, his answer is, what does he do? It's a practical answer. It's easier to get rituximab approved than to get bortezomib approved. So he'll give rituximab, and if that doesn't help the patient, he'll go to bortezomib. I don't know. Does that sound reasonable to people?
Yeah, that's what I was just going to say. Like you're sort of guessing if you don't have a clone. So hopefully one of them will work. Not always, but hopefully one. Rituximab is a lot easier for us to give. Luckily at Rush, at least, our oncologists are very aggressive, and if we would recommend bortezomib, then they are, at least our oncologists and our myeloma oncologists here are very, very supportive and willing to go with whatever we think. So our bortezomib is not that hard to get approved either, to tell you the truth. But I think you pick one, you go with it, you see how it works. The problem is that the Rituxan usually takes a while to kick in for a lot of our diseases. But you gotta start somewhere and then see the response.
And they are slowly progressive, as Dr. Glass pointed out. So
we have a very fabulous oncology program also. They are very supportive of us. And actually, as a matter of fact, in last 3 months, I have referred them about 6 cases with monoclonal disease, and somehow I'm seeing more and more. And they have been very supportive of that. So I appreciate that.
Hey, just a recent Jason paper actually showed 100% response rate for using DARA in PG and MID. So, you know, DARA has much less side effects than some of these other drugs for myeloma. So, you know, I think that might become the future. It might become DARA versus more rituximab, some of these patients.
Well, I think we are coming up to the time. If there are no other points, we can close our meeting. I thank everybody, especially the experts coming here and helping us out with this interesting case. Next one is in about a month. I will invite again all of you. It's a very interesting case we are working on. It's actually a case of, again, hematological malignancy. And Dr. Radvi last week presented a case, and Dr. Whittier, and they were talking about minimal change and membranous. And I think we have a surprise for you. There are other diseases which can happen in this condition. So I hope we send you the link. I hope to look forward to seeing you guys again. That's actually a very, very good case. I learned a lot when I was doing that. Thank you very much. Thank you very much.
Thank you, Dr. Rain. It was an excellent conference. You did a great job.
Thank you.
Thank
very
you,
much.
sir.
Thank you.
Amazing.